Donc on a 2 cas cliniques. Et je pense qu'on va pouvoir bien discuter. Le premier cas clinique, c'est un plombier qui a 35 ans. Et c'est son genou droit. Il a eu une luxation de la rotule à l'âge de 14 ans. Pas d'antécédents familiaux. Et en 2001, on lui a fait une arthroscopie pour ablation d'un fragment étranger dans le genou. On n'en sait pas beaucoup plus à cette époque-là. Il fait pas tellement d'activité sportive. Et après cette première luxation, il a eu des petits épisodes de subluxation, des petits symptômes. Mais depuis 1 an, il a vraiment des douleurs dans la vie de tous les jours. Il a le genou qui gonfle. Et il a des sensations d'instabilité, réflexe ou subjective ou objective, difficile à dire. Et le traitement médical est pas vraiment efficace. Il est un peu en varus, il a un épanchement articulaire, il a une mobilité normale, il a un petit signe de l'appréhension et il a des douleurs fémoro-patellaires. Donc on a demandé des radios et voilà les radios. Alors, Olivier Reynaud, toi qui es le spécialiste international de la radiologie fémoro-patellaire, est-ce que tu es d'accord avec cette interprétation? Est-ce que tu peux commenter un petit peu ça?
L'interprétation, on n'en a pas encore tellement. Il a une... Vue d'ici, elle paraît pas si haute que ça sur les radios, mais la mesure du caton des champs a l'air de dire que la rotule est haute quand même. Il n'a pas d'atteinte fémorotibiale. Il a une trochlée dysplasique. Donc il a les facteurs de risque classiques de l'arthrose fémoro-patellaire et un antécédent de luxation, hein, tu disais tout à l'heure?
Oui.
Donc c'est une situation qui se présente déjà pas très bien.
Ouais. Thomas Tischer, do you see something which is wrong on this on those X-rays, except the trochlear dysplasia and a little bit of patellar alta?
Little patellar alta, maybe I don't know, the medial patellar facet looks a little bit...
Thomas Tischer has a good eyes.
Probably this was a flake that got out and was calcified now, but we see that on the MRI, if we have one.
Okay, Elisaveta, you agree? Agree.
It's sort of intralesional osteophyte.
Yeah, this is strange. This is something strange, and so we can say, on peut dire que c'est une arthrose I101 à peine. Hein. Donc vous avez bien vu le signe du croisement ici. Il y a une proéminence hein, quand même. Donc c'est une dysplasie importante, une petite rotule haute, et on demande une radiographie en chousse pour être sûr qu'il n'y a pas de pincement fémoro-patellaire. Donc on a demandé un scanner. Un arthroscanner. Et voilà l'arthroscanner. Vincent Villa?
Oui, tout à fait. Donc effectivement, on voit les lésions cartilagineuses qui sont déjà bien présentes. Donc la situation se présente pas très bien pour ce patient.
Cécile, tu as un truc qui te... Toi, tu m'as dit quelque chose sur cet arthroscanner qui était vachement important.
J'ai dit quelque chose.
Ouais. Sur cette bosse, hein. C'est vrai qu'il y a une bosse.
C'est vrai qu'il y a une bosse.
Big boss, hein, Thomas Tischer. Big boss. This is the boss that you are talking about.
Yes, exactly. What Elisaveta said, it's an intralesional osteophyte. Probably we have to remove it and try to restore some cartilage together with realignment. And he was 37-year-old.
Yeah.
I would be a little bit...
35.
35. Yeah, probably I would, distalization, I don't know, the TG, was it?
No, we don't speak about treatment.
Okay.
So this is really abnormal, but Elisaveta, could you tell us something about the cartilage? It's missing, no?
Yeah,
I feel that some cartilage is missing
cartilage.
here.
Yeah, it's no cartilage there. It's intralesional osteophyte, but it's no cartilage over there. Probably it's the place where the detachment was a lot of years ago, and it healed in this way. But they are frequently healing in this way when the patients are very young. Yeah. Because if you're an old patient, you will not have this. Okay. But if the patients have removal, just lost body removal very young, frequently you see this overgrowth of bone.
So you see also the trochlear dysplasia, which is important, and it's a high-grade trochlear dysplasia with a bump.
One thing is, probably they not only removed, they did microfracturing, because most of the time you see this bump when it was previous microfracturing in very young patients.
Only removal.
So he did
loose body removal.
He did everything himself.
Yes, by himself. So, Elisaveta, you're the big specialist. This is a cartilage lesion on a patellar instability, but not so unstable. So what would be your advice in terms of treatment?
In this case, I would for sure recommend reconstruction of the cartilage, if you were asking about cartilage. And combined with patellar realignment, then you can choose, whatever you want. I agree with Stefano Zaffanini, what we are mostly doing our type of reconstruction, not on PA and PFL in this case, but anyway, I will add a realignment, and I will use probably here osteochondral scaffold for the reconstruction of this part. Because you strongly have a bone problem here, because you have to remove this part of overgrown bone, which will be sclerotic completely. You can see it on the CT. It's completely sclerotic, and so there are no cartilage there. And so you have to replace the bone level and guarantee the stability of this graft, because it's also very difficult to stabilize it because we have no shoulder on this side. And probably it would be not a bad case for allograft, but the allograft availability in Italy, at least for fresh allograft, it's very, very difficult. But I would try to use osteochondral scaffold in this case.
Okay. Vincent? Non, tu aurais...
J'ai rien de spécial à ajouter. C'est vrai que...
Tu ferais une chirurgie du cartilage sur...
Non, à titre personnel.
Non, et sur cette pseudo-bosse ou cette bosse ou cette anomalie de la patella, tu penses on la laisse comme ça, tu mettrais un coup de scie dessus, un gros coup de curette Non.
Non, je pense pas.
Tu laisses comme ça.
Oui, je pense pas que je la toucherai à titre personnel.
Olivier?
C'est tentant quand même effectivement d'aller aplanir un peu cette espèce de bosse de champignon sous-chondral, mais je pense que si je devais le faire, je le ferais plutôt à ciel ouvert, je pense, pour essayer de perforer après avoir réséqué plutôt que de faire juste avec une fraise sous arthroscopie, pour aller chercher un effet de cicatrisation d'un tissu de granulation derrière, qui a déjà un petit peu d'ailleurs sur le relief osseux, mais je pense que j'y associerais un abaissement de la TTA pour limiter un petit peu les contraintes sur cette zone-là quand même.
D'accord. And Thomas?
Yeah, I would remove it with a burr and try to reconstruct.
So you cut it with a saw?
No, with a burr.
With a burr.
Burr and water cooling.
Arthroscopically?
No, because you have to do a realignment surgery. So this is open surgery for me.
You will do open surgery?
I will do it open and also do some realignment in the tibial tubercle.
Okay.
And then use a burr and remove it completely. Then probably I would use a scaffold. We see this oftentimes, those ossifications when the cartilage regeneration is not working. So microfracture is the same, or just the healing, the spontaneous healing, which is a microfracture because when the fragment broke out, there was the bleeding surface open. This is what the body did. So would you augment it with a membrane and then the realignment, and then have a look at the bump if it's still bothering after the patella went down?
Nothing really on the trochlear side?
I would re-evaluate it after I put the patella distally and see how it engages. If the bump is still bothering me, it's open, you can remove it.
Okay, so Elisaveta, if I remember well on your talk, which was really instructive about the location of the cartilage damages, if it's on the medial side or on the crest, it's a good indication to do something.
No, it's not a good indication, but it's challenging, and I think we should do something.
Okay.
I don't say it with the best indication, and it for sure will heal. But you should do something on cartilage, for my opinion. I will never leave him alone, on 30 years old. If it will be 50, 55 years old, we can talk about leaving him alone. But on 30 years old, I'll for sure try to reconstruct.
And the microfractures are definitely bad.
I on purpose left microfracture out of my talk because there really no literature on microfraction, but by the experience and also for the biological purposes, microfracture on patella never got any type of good results because probably there are not enough cells, it's not enough clot. I don't know what is not enough. We can't do it properly in an upside down, I don't know. But it never worked really nicely.
But it's important to say that because Friday, it's a little bit like microfracture, was pretty famous and pretty common. Et probablement que les microfractures ou les perforations de Friday ne sont pas une bonne idée du côté de la rotule. Donc, les valeurs du scanner, puisque vous en avez tous parlé, sont élevées et vous avez dit que c'était important de faire une distalisation, une médialisation aussi, probablement, puisque la THGT est à 25. Il y a un tilt sur le scanner et sur le scanner, on voit qu'il y a des irrégularités et là aussi, on voit que cette rotule, elle n'est pas tout à fait normale, mais il y a un espace entre la rotule et la trochlée et l'antéversion, elle est à 26, c'est normal ça?
Aberrant.
C'est pas aberrant, donc c'est normal, quoi. Alors, les options chirurgicales, on en a parlé. Donc, vous voyez, il y a tous ces trucs-là. Quelqu'un ferait une arthroplastie? Non.
Non.
Non. Olivier? Non, non. Une prothèse de genou? Non. Non. Bon, alors le chirurgien qui l'a opéré a fait ça. Il a dit, il y a une patella alta, je vais faire une distalisation. Donc il a fait une distalisation. Il a ramené l'index à 1, bien, et la THGT est à 25, et donc il a médialisé au scanner. Le seuil c'est 20, donc il a ramené de 5 mm, une médialisation un peu automatique, et donc il a corrigé les paramètres anormaux qui ont conduit à la luxation de la patella, et il a fait un MPFL également qui est bien positionné. Et puis sur la rotule, eh bien on a ça. So this is what we have, Elisabetta et Thomas, in English. Vous maintenez votre indication, you keep your indication. So on enlève, you resect this, and then you do your surgery.
Yes.
Thomas, the same.
Yes, because I also saw some cases where the surface maybe is flush, it's restored, but the bone is causing pain because the force transmission is different when it's cartilage and when it's bone. So I would regenerate it, or try to do it.
Oui.
The point is that probably you also can just remove it, not leave it like this. I will not leave it like this. You can just remove it and hope for the best. Right. But the point is that you're already like this, you're already open. It's just a matter of what you trust will help patient more. Just removing it or put something in. It's a matter of philosophy, but it's not taken, I'm doing cartilage repair, I'm not doing cartilage repair. You're already there, so you have to do something. And if you trust that cartilage repair will help, I will put it inside, not just removing the bone.
Oui, donc ce qui est important, c'est cette proéminence et cette anomalie de la rotule, en fait. Donc il faut enlever cette bosse osseuse, ça c'est certain, et en profiter plus ou moins pour faire une chirurgie cartilagineuse. Et le chirurgien qui l'a opéré a fait une mosaïplastie du versant médial de la patella. Et donc voilà le résultat final. Donc cette bosse a été enlevée à la scie et puis un plot de mosaïplastie a été positionné. Voilà, this is the treatment.
Thanks. That only a short case, but this fits perfectly into the last case because you all see this big lesion here. And the patella, it's central, it's in the fist. You see the X-ray. So the first question, would somebody do something on the osteo side? like a tuberosities transfer, or the TTTG was below 20. So he had another problem of mild tracking.
But Thomas, there is a problem with your X-ray.
Yes. He always knows. It's not perfectly performed. You know that the posterior condyles have to perfectly overlap, and then it's, yeah. But this is real world, what we get. And
no problem.
If I had the feeling that there was some trochlear dysplasia, then I would make it new. In this case, I did not do another X-ray, but yeah. So, yeah, would you do some osseous realignment? Maybe do the history. He had playing basketball when he was younger. He had knee pain once in a while, and then it got a little bit more. The knee was full range of motion. He had pain on patella movement and just the pain behind the patella. No med tracking, the J sign was normal.
No, I would not think in this case. Maybe added CT, maybe look it's a little bit better, a little bit more deeply in the diagnostic, but as a tendency looking on this X-ray will not do any type of bone alignment.
Anyone else?
And for sure go for, if it's symptomatic, strongly symptomatic, or go for the reconstruction of the cartilage. It's because he's young and, you know, like very active. This is, here you have the question. In the previous case, you have no question to operate or not to operate that guy. Here you have a question, operate or not operate. So 30 years old, my answer is yes. Highly functional requirements, yes. 50 years old, 60 years old, in this case I would not operate him. But on basketball player of 30 years old, yes.
I mean, here it's interesting, because for sure on the X-ray it's no patella alta. But if you look on the MRI and see the trochlear patella overlap, then you have a relative patella alta. That's
why I said I would add a CT scan to look a little bit better.
You see there's only a small overlap in between here. So you could discuss to do some osseous realignment. Just to say, I didn't. So this was the intraoperative aspect. You see the defect, not quite the typical traumatic defect. The borders are still a little bit degenerative. You can undermine the cartilage. You see that it's a long ongoing process. It has unstable flaps. Then it's the normal process. And in this case, the advantage is you can do it arthroscopically, which is a lot less morbidity than when you do open surgery. Then you do the microfracturing, and as we heard, I wouldn't do that in isolation. And then you can put in some kind of scaffolds. You can either do it in water or you can dry up the joint. And this is a hyaluronic acid membrane, the Hyalofast. It's a three-dimensional matrix. And here you can see the water is out of the joint. You can see how nicely it fills in the space, and it gives the cells that come to the defect. And the cells not only come from the bone, because what I always do in these cases, I do some partial synoviectomy, I try to induce some bleeding, and I also in the patella cases do some microfracturing in the notch to get some bone marrow contents in the joint. And this is how I treat it. And if you look at the MRI, we have a 6-month and a 2.5-year outcome. After 6 months, you clearly see everything is still active. It's maturing. It takes a long time for the cartilage to mature. And also you see the subchondral abnormalities. They can last over 1 or 2 years. You see the abnormalities in the subchondral bone. But then here after 2.5 years, you see the subchondral plate nicely rebuilt. Of course, the defect is fully filled, but here, if you look closely, you see some alterations. So this is not purely hyaline cartilage, but for the time being, the patient is fully pain-free, and I think he can go back to sporting activities. How would you recommend regarding sporting activities? Would you allow him go back to unrestricted sports, or would you tell him no, just be happy that you're pain-free and do some light activities? Elisabetta and the others?
I'll restrict sport activity for 1 year. When looking my MRI, 1 year, not completely nice, but for sure looking at this one of 2 years and a half, I will not restrict his sport activity. I will tell him, live your life, do whatever you want, and we'll see. Because they are doing it also for coming back to sport. Because if you say him, don't do sports anymore, you can leave him alone and not operate him.
Just a question, Thomas. If do you think that there is a place to do some radiofrequency or coblation on this lesion?
On this lesion, not, but in the patella, yes. Because when we look at the patella cartilage, often it gets frayed in the beginning, and there's still lots of cartilage. Okay. And I used lots of shaving, but I also used the coablation, which, at least from a visual sign, looks nicely after you electrically smooth it. But there's almost no evidence in the literature if it really gives the benefit over the shaver. Okay. It's a highly controversial topic if you should do that or not. At least from a visual and optical point, and from the evidence I personally have, I think it helps. But in the literature, the science is low on that topic.
Thank you.
Thank you so much. And on va continuer, en français, avec David Dejour, du coup, qui va enchaîner sur les traitements conservateurs de l'arthrose fémoro-patellaire à ciel ouvert.